Okay. So good evening and welcome to our first One Heart Clinic patient forum that we've actually put together. My name's Ravi Asamal. I'm one of the cardiologists and founding partners at One Heart Clinic. I'm joined by my two friends and colleagues, Dr. Sayan Sen and Dr. Fahar Khan. And before we progress, I also want to thank Stephanie Becker, who is our practice manager at our city sites in general, doer and sort everything outer, for simply putting this together after I had a 5-minute discussion with her saying, I think we should do this. Education is a big part of what we do at One Heart Clinic, because if we educate our referrers, we have to keep ourselves up to date. And actually, there's a lot to learn from our patients, and I think we've been missing an opportunity. And that's how this all came to be. One Heart Clinic is a partnership of 3 friends and 3 cardiologists who have a shared vision on patient care. Fahar Khan and I were at university together. We went our separate ways, reconnected after we got our consultant post. When we were at university together, it was crystal clear to me that there was something special about him. It was so special that I used to copy all his homework and notes so that I scored well in my test as well. Shai is the most gifted interventional cardiologist that I've come across. His work was so good that I decided I had to stop doing it myself, because in his hands, our patients clearly got the best treatment. And we all look after patients with the same ethos. And in essence, what we decided is we wanted to build a clinic that differentiated ourselves from what's on offer in typically the big hospital groups. We wanted something that we would be proud and feel safe for our own parents to attend. And I think at One Heart Clinic, we've done that. And hopefully some of you who joined us today would have felt the benefit of this. And certainly over the last 5 or 6 years, this has got a lot bigger than we thought. We are now have 6 clinics and building more, and have 30 cardiologists that we work with, all handpicked with the same ethos. And today is a real privilege, because for the first time, we're going to be speaking to you about potential questions that we hear from our friends, families, and from you that worry them, and also that we need to kind of sometimes struggle to answer. We have to learn. And hopefully by having this discussion with you today, we're going to learn a lot more. So it's going to be a panel discussion. I'm, for whatever reason, chairing it, but I'm very much going to bring in Fahar, Shai, and some of you as and when you have something to say. Fahar and Shai, please interrupt. Fahar, you're kindly going to just field the Q&A section. So if you see any questions that you think are absolutely critical for the group to kind of hear about, then please just interrupt me. There's no right or wrong answer. And I'll say straight up front that you're probably going to get a diversity of opinions. The 3 of us are 3 different people. We have different views on what makes a good diet, what a good exercise plan is. And sometimes we downright disagree. Sometimes we won't know the answer, and you'll probably see one of us furiously on the internet Googling what we think is the answer. But that's the way things genuinely occur. And really amongst us, please, you're amongst friends. So any questions, just ask, and we will happily do our very best to answer. So, and the way we're going to do this is just give you a bit of a background and let you kind of get an idea of where we are, and then hopefully focus on some topics that resonate with you. So today in the United Kingdom, there's going to be just under 500 people who are going to die from a heart or circulatory problem. And to put that in context, that's 1 every 3 minutes. Typically, there are about 300 hospital admissions due to a heart attack. So that's 1 every 5 minutes. And there are about 7.5 million people living with cardiac problems in the United Kingdom today. And that's why we do this job, because there's a lot of people out there we can help. And there's a lot of procedures, technologies that we can utilize to make people feel better and potentially save lives. And what I love most about this job is what we do today is highly likely to be outdated within 5 years. Certainly there are procedures such as keyhole valve replacements that Dr. Shai Sen is an expert at, that 10 years ago would have been thought to be absolutely impossible. And around the corner, there are medications that are coming out that are further going to revolutionize how we treat our patients. So, as I said, there's about 100,000 admissions every day. what was really kind of noteworthy is that in the 60s, if you had a heart attack, 7 out of 10 people who had a heart attack in the 60s would actually die from it. Today, we've actually reversed that. More than 7 out of 10 people survive that heart attack. And that's due to the fact that we have emergent technology, that people take their heart health more seriously. And there's been a lot of research and investment into improving cardiac care. And it's estimated that around 1.4 million people are alive in the UK having survived a heart attack. And that's roughly around 1 million men and 380,000 women. So here's a graph showing just how brilliant that improvement has been in terms of survival. So at this stage, I'll bring in my colleagues, Shai and Fahaf. Guys, what do you think? Why, in your opinion, having kind of seen what's been happening, how come we've seen such an improvement? What would you put this down to?
So I'll take that first. I would say it's prevention. I think education and prevention. So increasingly now, we're lucky in that our patients often come to our appointments more knowledgeable about the condition or just as knowledgeable as we are, which is great. It means that we're getting the disease process much earlier, and hopefully we're preventing future heart attacks and strokes. So I think education's really made a massive difference here in prevention. And I think over the next 10, 20 years, I think the NHS will move towards prevention as well.
Yeah, I think that's the only way the NHS will survive, really. I think, thankfully, the new kind of health minister appears to be saying the right things. So in terms of prevention, any particular medication that you think, Shai, that has been particularly useful in this regard?
So I think stopping smoking has been key. And then statins, I think, have come in.
Oh, statins, your favorite.
And made a difference. And whilst they're controversial, we'll mention the statin word at this stage. I'm sure it'll trigger a lot of questions, with the audience and the attendees. But I think statins have had a massive impact.
Okay. So to try and make this interactive, what I've done is I've put some polls up. So let's give you the opportunity. You've got 3 questions here. And I'll invite you to answer these 3 questions. Number 1, are you on a statin? Yes or no? We can't see who's answering this. So, there's no issues with I can't pronounce the word, about being anonymized or not. The second question is, have you ever had side effects if you've been on a statin? If you're not on a statin, obviously that's irrelevant. And finally, as a result of these side effects, have you ever stopped a statin? So those are the questions. It's good to see that nearly 2/3 of you have already answered. And I'll give that another 10 seconds before I close the poll. And I have to say, you're the best audience. When we do this with our GP colleagues and junior doctor colleagues, we typically get a response rate of 50%. With just under a minute gone, we've had 90% response. So you guys are by far the best we've had. So let me end that poll. Let me share the results with you. So let's go through that. So about 60% of you are on a statin. 11% of you have had side effects. Well, obviously 36% haven't. Are not on a statin. So 11 actually out of 64%. So a reasonable percentage. And a small percentage of you have actually stopped the statins as a result. So yeah, that kind of fits with what we see in real life. And my view on that is that statins definitely have side effects. The published data is that we normally have around, the published data would suggest about 10% of people on statins will have side effects. And in the big trials, the people who had side effects on statins were similar to the people who were taking placebo. So it didn't actually make a difference whether you were on a sugar-coated tablet or statins, you had the same side effects. But in real life, we tend to see more of this. So let's frame this around a case, if we will. So I'll restart my PowerPoint.
So we've got a question from the audience about statins, actually. We've had 2 fantastic questions, actually. Yeah. One is around statin after heart surgery. I think we get some clarification on that. I'm assuming that here the question is around bypass surgery or surgery for blocked artery. So that's one great question. But actually, before that, we had a fantastic question about what single recommendation would you make to improve heart health? amongst the panel. So I'd answered in the box, and I can tell you what I stated. I said that walking 30 to 40 minutes, 3 or 4 times a week is probably the single most important intervention that you can do to help improve your heart health. So I'd be interested to hear what my colleagues think about that. These 2 questions have come through.
Yeah, so in terms of the single, when I say it's a single intervention, actually it's going to be that what I'm doing is about to cheat. I'm going to give you a single concept which has multiple interventions. We've kind of, healthcare traditionally in the Western world and certainly in the UK has been a reactive enterprise. You wait for a problem, you wait for a heart attack, you wait for chest pain before you start taking things seriously. And we have a really successful and evidence-based program called cardiac rehabilitation, which, if you're lucky enough to get it, will reduce your chance of heart attack, a recurrent heart attack, by about 30–40%. I'd love to see the concept of cardiac rehabilitation move to cardiac prehabilitation. So we actually go and take a proactive approach and find those people who are at risk of heart attacks before they have a heart attack or before they develop symptoms, and really use all the excellent tools, be they medications, be they exercise programs, dietary programs, to minimize the risk of them ever having any form of cardiac event. And that's going to take effort, but I think we're hearing the right things now in terms of actual kind of a paradigm shift. So that's my view. Shai?
So I'm with Fahar. So I would say regular exercise and keeping your weight under control. That would mean that you're exercising your cardiovascular system, but also by keeping your weight under control, you're managing your diet appropriately as well.
Perfect. So let's kind of frame it around, and these are kind of cases based on true stories. Obviously, we've kind of embellished them with a bit of fiction. So typical case here is that one of a 73-year-old retired school teacher, slim, active, does all the right kind of exercise, a combination of swimming, Pilates, also some kind of weight training thrown in there. A non-smoker, teetotal, pescatarian, basically a saint from what I can gather, no medical history, no medications, had a well-person check. Her blood pressure is the kind of blood pressure I dream of having, but have never quite managed, 120/80. Never been diabetic, but her cholesterol was always normal as she was growing up, but post-menopausally, it's kind of gone up a bit and has continued to rise. And for the first time, she's been told that she should have a statin. And her total cholesterol was 7.4 with an HDL, which is a high density lipoprotein, allegedly your good cholesterol, at 1.8, and then something called your non-HDL cholesterol, which is all the bad cholesterol, quite high. And the number you're looking for your non-HDL cholesterol is less than 4. And typically the NHS suggests that your total cholesterol should be less than 5. She's offered a statin and doesn't want it. What do you think, Fahar Shah? Is that a reasonable approach?
So I'm muted, but Farah isn't. So there is a question that somewhat fits into this actually on the chat about keto diet and the fact that the keto diet is high in saturated fat but eliminates all sugar. What are your thoughts, Ravi, on the keto diet?
Yeah, so the keto diet. So as you know, Shai, having worked with me for 7–8 years and known me for 10 years, I've pretty much tried every diet out there because I look at food and I tend to eat it and as a result get heavier. But one thing is clear about the keto diet, the traditional keto diet, there's been one study that's been done that shows that it doubles your risk of cardiovascular events. But having looked back at that, if you look at the original keto diet, the problem with the keto diet was that it was low sugar, low carb, but it was no restriction in terms of processed food, trans fats, absolute poor quality, unhealthy fat. Whereas now, people, if you notice on social media, no one talks about the keto diet. People talk about healthy fats. People talk about the carnivore diet, which is basically protein, but no, I mean, I've seen kind of keto posts where people take burgers, cheese, eggs, mayonnaise, stick it all together. That can't be healthy, and surprisingly enough, it wasn't. But I think for me, a diet that actually is balanced and focuses on real food with high quality, healthy fats. And for me, I think the key missing ingredient that we have in our diet in the UK is a lack of emphasis on protein. So we do not eat enough protein. We eat about, the official recommendations are 0.5 grams per kilogram, where actually we should probably be having 1.5 or 2 grams. So if you're 80 kilograms, you should probably be having 120 to 160 grams. And actually good quality protein will keep you full and is essential for increasing your HDL and keep maintaining muscle mass. So that's my take on it. I think, no one really takes on the keto diet, but there are people who take on high protein and modified carbohydrate. I think cutting out carbohydrates, which I've done in the past, is utterly mad, but having good quality whole grain carbohydrates that take up no more than, say, 30%, 40% of your total energy intake is very sensible.
Brilliant. Questions are coming thick and fast and timely, because this patient doesn't want a statin. And so one of the questions was, are there any developments in statins? Atorvastatin's been around for quite a long time.
Yeah.
I agree, it's been around as long as you and Fahar. So what else is out there?
Well, there's plenty for a start. I mean, the first question is, does she need any form of medication? I mean, she's basically a saint. And the reason she's been offered this medication is because if you go on the NHS website or see your GP, you will probably be offered something called a risk calculator, and they tend to use something called a Q-risk-3, which allows you the opportunity to put in your age, your gender, a range of other variables, as well as your cholesterol and your blood pressure. And if she puts all her data in as I presented to you, her heart age, which is the age that it suggests that you are, is 73, which is her real age. And it gives her a risk of having a heart attack or stroke within the next 10 years as moderate, between 10 and 20%. And above 10%, 10-year risk is the trigger point for your GP to offer you a statin. Now, this is a great way to approach a population if you want to reduce the risk of a heart attack or stroke in the population. And that's, in essence, what our GPs are asked to do. But for the individual, this will probably put a whole load of people on statins who won't necessarily benefit from it. And conversely, will fail to capture a whole load of people on who would actually benefit from statins, but don't magically come up as a 10% risk. So I think the key here is to treat the individual and kind of look at it a bit more in a bit more kind of personalized manner, a bespoke strategy. So, I mean, what do we do in clinic, guys? What would you do with this lady?
So I would individualize her cardiovascular risk.
Yeah.
So sure, she comes across with this population screening tool as being high risk.
Yeah.
But what I want to know is this cholesterol plugging up her arteries? Is it being layered on her coronary arteries or her carotid arteries? And there are some biomarkers now that will tell us whether or not she's at high risk or low risk of a future cardiac event. Yeah. So generally what I tend to do is do a CT coronary angiogram, calcium score, a carotid Doppler, and then some of these blood tests, including LPA, apolipoprotein A and B, and then sit down with the patient and have a discussion with regards to treatment options, whether that's nutraceuticals, so things like plant sterols and ready-use rice extract, or statins, or alternatives to statins, which I'm sure we'll come on to. So that's how I'd approach things. Fahar?
Yep, absolutely. I think we get a much broader global risk assessment for this patient. It's really interesting because on this subject, and I know you talked about the diet, there's a good question about olive oil, for example, in the diet. And a question has come forward is olive oil as good as taking a statin? And is olive oil the elixir of life? Now, I've been rubbing olive oil on my face all my life, so
it's so smooth.
So is olive oil the elixir of life? What's your secret for looking so young?
No, it's a filter that comes into the camera. So olive oil is a very healthy. It's a part of the Mediterranean diet, which is the evidence-based diet, but it's not a replacement. So let's kind of really try and categorize it. For me, statins are almost mandatory if you've had a heart attack, had bypass surgery, have had angioplasty, or a stroke. I think, would anyone disagree with that? There's a statin, a medication with proven benefits to reduce your risk of future cardiovascular events. It would be hard not to prescribe it. Obviously, some people will have side effects, will not tolerate it, and there are novel treatments available that are at least as good as statins, but unfortunately are not yet widely available, as there may be a kind of a cost barrier to it. So let's kind of talk about that. So those people, that group of patients, what we call secondary prevention, the argument for statins is very strong. Where there is tremendous debate, and I think rightly so, is that primary prevention group, the kind of group we're seeing here, who are ostensibly well, thankfully have never had a cardiac event. But a number comes up saying, actually, it's above 5, you should have a cholesterol. I think what we all agree between us is that's not the right approach. And what we do is, what Shai has said, is we do this procedure, which is completely revolutionized how we look after people with suspected chest pain, but also we now use it to guide whether people should be on a statin. Because at the end of the day, I tell the patients I see in my family and friends, the number you see on the piece of paper is a number. It only, for me, means something if you can see that it's causing a disease process. So a CT coronary angiogram will tell you whether you've got any form of plaque, a fatty deposit, whether that's hard calcified plaque or more worryingly, soft non-calcified plaque. And in the past, there were concerns about radiation doses. We use a 640 slice scanner. And to put that in perspective, the kind of standard criteria that's considered acceptable is a 64 slice scanner. We get beautiful imagery at very low radiation doses. And we can use this. So if we have someone with a calcium score of 0, so Shai, if this lady had a calcium score of 0, i.e. no hardened plaque, and completely normal coronary arteries, would that be fair enough? Would that be enough? And you've done the same with the carotid Dopplers. That's fine. There's no fat in either her carotid bed or her coronary bed. Would you be comfortable leaving her off a statin?
Yes, so I think that's exactly the kind of patient we want to identify, people who don't need a statin. And I don't think this person wouldn't need a statin. It would be nice to reduce the LDL cholesterol because that is related to your cardiovascular risk. And there are alternatives, so natural cholesterol reducers, which is one of the questions. So I tend to recommend plant sterols, 2,400 milligrams a day, usually taken 20 minutes before your main meal, but generally if you just remember to take it every day.
How easy do you find them to swallow?
They're quite large, so it's broken up into several different pills, but that will reduce your LDL by 25%. So, and has been proven is in guidelines, as well as red yeast rice extract as well. So that's another 25%. So there was a question from one of the attendees about natural cholesterol reducers. I think there is a place for them in our treatment, particularly in patients like this. So that's my approach for this patient. I wouldn't jump to a statin. I'd start a nutraceutical, and then keep an eye on it.
Yeah. And what diet would you recommend for this cohort of patients with a high cholesterol who you're keeping off statins? But because actually looking at that, I'm showing you here a picture of her coronary arteries, which are crystal clear. I mean, I suspect they're probably clearer than mine, which is good for her and not so good for me. So, but what dietary? So we'll be asked, what should I eat?
I'd go for a Mediterranean diet. The things I try to avoid, cheese, butter, and red meat, are the big ones, mainly because they're the most tasty. And 150 minutes of moderate exercise over the course of a week. That's generally my advice. 2 of those exercise sessions should be weights. Yep. And so that's my advice for a healthy life, to keep her arteries like this. But I'll ask Fahar what he does.
Yeah, so my advice in these circumstances would be oily fish. I think has been shown to have a significant benefit in helping in the diet. Lots of fresh fruit and vegetables, and the Mediterranean diet. There was a very interesting question about a ketogenic diet, and we kind of addressed that before. There's actually quite a lot of really good questions coming in about diet, and I'll just address a couple of them if I'll put it to the panel. One is the vegetarian. A vegetarian diet. What are the thoughts on the vegetarian diet? And on that line, there's another question about, if we're talking about protein, is it better to get your protein from meat or from plant-based products? So 2 really good questions are around that. So for those people who don't eat meat, I think there's a little bit of focus on what do we think about this?
So, I mean, I think a plant-based diet is absolutely fantastic. It's a very healthy diet. The problem is it has the potential to be very unhealthy as well. So if you're eating plants, that's great. But if your plant-based diet is supplemented with high levels of saturated fat or refined carbohydrate, for me, sugar is the real villain here. Sugar that you ingest, if you don't burn it off, basically gets converted into fat. And once you saturate the natural fat deposits, it tends to cluster around organs. You become more insulin resistant. So plant-based diets can be very healthy, but equally, being vegetarian doesn't guarantee you good health. You need to make sure that you don't eat too much refined carbohydrates, that you're not in a calorie excess. And protein, getting protein is absolutely 100% possible with a plant-based diet. You do not really need to resort to meat or powders, but you just need to be a bit more thoughtful, perhaps. And eating kind of the rainbow in a plant-based diet will keep the gut microbiome healthy. I tend to try and have something that's fermented in terms of helping with the gut microbiome as well. So I think plant-based is excellent, but with the usual caveats of avoiding kind of unhealthy foodstuffs, even whether you're an omnivore, carnivore, or plant-based. Any other questions there, Farhan?
Lots of questions firing in. Just with regards to going back to statins, there's a question about the general knowledge of GPs with regards to statins. Are they appropriately trained? I would say that they are. And we do a lot of work with primary care to make sure that they are appraised of everything. But we're lucky in this country to have very well-versed GPs with cardiology.
Is there a difference amongst statins? That's another question that seems to come up. Is it the same for everybody, or what's your thoughts on that?
So I agree that atorvastatin is slightly outdated. My preference is rosuvastatin, slightly better risk profile, a bit more potent. But Ravi, Fahar, what do you choose?
Yeah, so I mean, rosuvastatin is for me the one that I go for, because what tends to happen in the end, kind of in previous practice and what I've seen elsewhere, is you start on atorvastatin, you get side effects, and then you go to rosuvastatin 5 milligrams. So my view is, well, why go through that whole process? Let's just put you on the statin that's least likely to give you side effects. So rosuvastatin is definitely what I tend to go for. I start at 5 milligrams if there are concerns about side effects. I aim for a target of 10, and in people with very high cholesterol, 20. It's probably a good time to just address some of these issues which are contentious about statins. So first of all, when you have your blood test, and a lot of us can now see this on the NHS app, we see all these different parameters. What does it all mean? You have your cholesterol, which is your total cholesterol, and the figure that we're all told is around 5. I can tell you straight away, mine is comfortably above 5. Your LDL, which is your low density lipoprotein, which is your bad cholesterol, and your low density lipoprotein has a kind of a low proportion of protein and a relatively high proportion of fat. And the role of the low density lipoprotein is to carry cholesterol to all parts of the body. It's important to say at this stage that we shouldn't forget cholesterol is a really important molecule for cell health, for brain health. So that's why we have it, to actually transport it to all parts of the body. The problem is LDL, low density lipoprotein, has a habit of taking cholesterol into cells and getting stuck there. And that's a problem if you get into the walls of vessels and you get stuck there. Thankfully, we've got a protective mechanism called HDL, which is a high density lipoprotein, a high proportion of protein. And the role of high density lipoprotein is to actually go and take cholesterol away from potential areas where it's deposited, such as vessel walls, to the liver, where it can be excreted. So cholesterol is not an enemy, it's not the villain. And actually, most of the cholesterol that you have in your bloodstream is made by your liver. What you actually eat only contributes to about 10% of your total cholesterol. So let me ask a question to you, chaps. Do you limit the number of eggs people should eat a week?
I personally don't. I think it's also to do with how the eggs are prepared. So I know
so poached eggs,
boiled eggs. Or boiled eggs. I mean, boiled eggs, I think I wouldn't restrict it. It's a good source of protein, and
so I think that's commonly now accepted, that you can eat as many eggs as you choose. It's not going to raise your, actually very nutritious. But cholesterol is our friend. However, the problem with cholesterol is the way it's transported, and then an imbalance of how it's either taken into cells and fails to get out. And once you have the kind of fatty deposits in the cells, they attract an immune response. So you get white cells going in and forming what we call foam cells, which are big fatty deposits, which can then create plaques that rupture. Triglycerides are another form of fat that are thought to be kind of atherogenic, i.e. causing buildup of narrowings in the arteries. And I've actually noticed in our patients, and I don't know if you've noticed, that the more exercise that anyone I've seen does, the lower their triglycerides. So that's something that I always look as a marker of how much exercise you do. So side effects, let's talk about side effects. In the published data, it's about 10% and it's matched the placebo, i.e. it shouldn't, whether you're taking a statin or a sugar-coated tablet, both groups get the same amount of side effects. But in real life, it's kind of closer to around 30, 40%. And we know that even in people who've been treated with a heart attack, there's potentially in some studies a 50% discontinuation rate at a year. So what are your thoughts on side effects? Why are our patients kind of experiencing them more than they would in the studies, for example? Any thoughts?
I think Go on, Shay.
I've got to say most of the side effects are experienced before we've even prescribed the medication. So there's a lot of fear about side effects, developing side effects, knowing people who've had side effects, rather than actually suffering from side effects once we start. I think when we drill down to it, it's actually generally not the statin that's causing the discomfort. So I generally persist with the statin, or at least have a trial off with the proviso that we all agree that if the pain is still there and you're off the statin, it's not the statin. So the vast majority of patients that we start on, when you have an open conversation with them, will remain on statins without any problems. So
just to, I think in the interest of time, I'll just kind of add a couple of things and then move on to the other topics which are as important. So side effects tend to be overstated. There was a very elegant study done by a colleague of ours named Darryl Francis, Professor Francis at Imperial, where he basically gave 60 people who had previously been intolerant of statins due to side effects a little pill in a jar and made them take it for several months at a time. Now, you rotated the pill, so you either got the statin, you got a sugar-coated tablet, or you got nothing. And regardless of what you got, all groups got the same level of statin-like side effects, which suggests there is what we call this kind of nocebo effect. It's almost your mind willing you to have these side effects. But there are some people in whom is a genuine intolerance, and typically that's muscle aches. And thankfully, there are newer agents, which we won't dwell upon, but they do exist. So if you are on a statin and getting muscle aches, there are newer agents such as Nustendi, which basically doesn't work on muscle, so you do not get muscle aches, and some injectable therapies, one called inclisiran, which is very attractive because you theoretically will only need injection every 6 months, but they're reserved for people who have had heart attacks and who are intolerant of statins. Give it 5 years, I suspect that may well be the modality by which we are all getting our cholesterol-lowering treatment. I'll add a couple of things about diabetes and dementia. Statins can increase your risk of diabetes, typically by around 10%, and that's typically at the high dose of statins, both rosuvastatin and atorvastatin. However, that risk of diabetes does not lead to an increased risk of death, and overall, the benefits of statins are thought to outweigh the risks in this regard. Statins do not cause dementia in the well-conducted trials, and specifically in a group of patients with heart failure. It actually resulted in a 30% reduction in level of Alzheimer's. There have been retrospective studies that looked at people who got dementia, and they noticed a significant number of them were on statins, but that's just an association. The reason they were on statins is because they probably had strokes, which in itself may have been causative for their dementia. So those are two kind of issues I'd like to tackle head on. I think we've spoken already about diet and exercise. I've shown you the cardiac CT. So let's now.
So Ravi, whilst you're on the CT, there is a question about lipoprotein. There was also a question about when should everyone have a CTCA? Should everyone have a CTCA? What age would you do that? So as our imaging expert, what are your thoughts?
So I have to say this has been one of the most important advances in imaging. And I'll say this to you, I think we are now at the point where the radiation dose is low enough for us to say this is a safe and effective screening tool, and we certainly used it in that regard. And my view is that if you have a strong family history of cardiovascular disease, if you have a high cholesterol level, as we've seen here, but otherwise healthy in every other way, if you're worried about your heart health due to previous habits, such as smoking, or you're diabetic, these are all very high risk factors. I think a CT coronary angiogram is an excellent tool. The problem is also cost. So if this costs tens of pounds instead of hundreds of pounds, we know that the CT calcium score is validated as being one of the most potent predictors of cardiovascular risk, above any cholesterol marker. So it does have a role. I think at the moment it's one of the issues, one of availability and cost, but that will change. The final thing I'd say is even if you do one of the kind of calcium scores, which is without a dye and cheaper, we know that there is a cutoff of a calcium score of 100 that allows us to risk stratify. So if you have a calcium score of less than 100, that means you've got very little calcium relatively. We know that if you've never had a heart attack or stroke before, that you need to treat 100 people for 10 years to prevent a heart attack or stroke. Whereas if your calcium score is more than 100, you need to treat 10 people for 10 years to prevent a heart attack or stroke. So it's really, really helpful in that regard. Putting CT to one side, I'd like to bring to your attention a blood test that if you haven't had, I would strongly recommend that you do. For me, this is a blood test that everyone who is being assessed for high cholesterol should have. This is something called the lipoprotein A, Lp(a) we call it. And this is almost like a turbocharge of having high cholesterol or an increased LDL. So you can have people who are healthy, exercise, diet is impeccable. They're basically saints, but they have heart attacks at the age of 35, 40. And we've seen this, and we see this kind of unfortunately week in, week out. And what's been found is that a lot of these people will have elevated levels of this dangerous fatty deposit called Lp(a). And Lp(a) is basically this coating around your standard LDL molecule that almost turbo boosts the ability of the fatty deposits to enter the vessel wall, and critically, it prevents it from leaving. So almost makes it stick to the vessel wall. About 20% of the population have high levels of Lp(a). It's more common in Black and South Asians. And currently, keyword here is currently, there are no drugs to lower, but there are many in the pipeline. And about 4 days ago at the American Heart Association, 2 preliminary trials were announced, one for a tablet, one for an injection, that reduces your Lp(a) by 80%. So if we were to do this again in about 2 to 3 years' time, we'll be talking to you about drugs that independently reduce this. And this is even if your cholesterol is completely normal, if your Lp(a) is elevated, that puts you at increased risk. So this is something that you only need to do it once, by the way, because whatever your level is now, it will stay like that unless you take one of the newer treatments when they come out. Shai Fahar, have you checked your Lp(a)?
Well, I haven't.
Okay, we'll sort that out for you. And Shai?
There's a question regarding the LP of a number of 188. What do you think of that? One of the patients has put that forward.
So okay, so below 75 is considered low risk.
Yeah.
Above 75 is considered higher risk, and above 125 is considered significantly higher risk. So 188 it would be very much that high risk end, and that's the kind of number that I would be proactively looking for evidence of coronary plaque. Kind of insisting on absolutely exemplary diet, a carefully regimented exercise program. And even though statins don't reduce Lp(a), but those are the kind of people that you would probably have a very low threshold for you've got to do everything you can that's currently available. And as and when the medications come out that have proven benefit in reducing Lp(a), as well as preventing subsequent heart attacks and strokes, those are the kind of people who need to be straight on it.
So as not to worry the patient. So with somebody with a number of 188, it's also part of a global risk. So we need to know what else is happening.
Yeah, absolutely. And I just go back to what I said. It's a number. Yeah. It's a number, right? It doesn't mean anything horrible. It's a number, but that number, like a high cholesterol, ought to make you look a bit further. So we're going to move now anything else in terms of questions?
Yeah, so well, there's a couple of other themes that have come. I know we're probably going to move off this topic. There's a couple of themes that are really coming through. One is about the weight loss drugs. I don't know if you're going to address that today. And there's, I think we need to do this again for sure. There's some great questions coming through. Really great themes. So one is the weight loss theme that's come through quite a bit. And there's a little bit more about AF and ablation. But I think the weight loss is the one that is really coming through quite nicely. So I think
maybe just before we finish, we'll have a little discussion on that. Shai, I'm going to hand over to you here. Can you tell us? I think this is one of the best messaging campaigns that I've seen in my lifetime. What does someone feel like when they're having a heart attack?
So it should feel like a pressure, a squeezing sensation, like someone sitting on your chest, like an elephant sitting on your chest. It's a constrictive feeling, and this picture really does depict it perfectly. So a lot of patients come to see us with chest pain, and quite rightly so. It can be slightly different to that, very rarely. But generally, we get worried about chest pain when it's not really pain, it's not sharp discomfort, but it's more a pressure, a squeezing, or a tightness. So if you have that, it's worth seeing your GP. Also, new onset indigestion as you get a bit older can be a sign of coronary disease as well. So any discomfort in your chest, have a low threshold to discuss that with your GP.
Yeah, I never tell you when I've got indigestion anymore. You're always telling me I need to go to hospital. So yeah, very helpful. I think that picture paints 1,000 words. Shai, can I ask you to talk us through? This is what the kind of heroic procedure you perform. Typically at 4 a.m, I got too tired to do it, so I stopped. What's happening here? So this is a chap who's come in with acute chest pain, called 999, been taken to hospital. What do you land up doing, and where do you do it?
So very much, I'd hope that this would happen to none of the attendees. But if you do have significant artery disease, so if we look at just the panel on the left-hand side of your screen, you'll see this dark line, like a pipe coming down from around about 11 o'clock to 5 o'clock on the screen. And you can see on the right-hand side, it looks a lot bigger, a lot fuller. And that's because a stent has been placed to open up that blood vessel. And that's the schematic on the right-hand side. So you've got the blood vessel, you've got the atheroma, or the fat that we've been talking about. So that's causing a narrowing. And then we insert a little wire. Over that, we pop a stent, which is on a balloon, usually through the top of your wrist. Usually you're awake, you're talking to me. It takes about 40 minutes and you're done and dusted. And if we do this as an elective setting, i.e. you've got chest pain, you found a problem, you fix it, you're home in the same day. If you come in as a heart attack, you're usually home within about 48 hours.
Perfect. Okay, so let's do another case. This may resonate with some of you. 49-year-old cardiologist, generally well. Lots of stress recently. Both his kids have started senior school and hating it. Everyone's having to get up earlier for school runs. Homework's now a family event. Maths is very difficult for the kids and the dad. It's resorted to an increased level of coffee and acid reflux symptoms, which you can assure Dr. Sen is nothing to do with the heart. It's all acid reflux, responds very nicely to Gaviscon. And he's now getting skip beats, thudding periodically. So Fahar, as our electrophysiologist, what are your thoughts? These are palpitations. What are your thoughts about this history?
I think you've got my CV there, Ravi. So skip beats is a very, very common symptom. We sometimes comes under the umbrella of palpitations. So it's a very, very common symptom. If it's only lasting for a few seconds, it can often be a benign entity. It does need assessment, but usually the typical benign entities are short-lived, lasting for a few seconds, sometimes can feel like a missed beat. And in the absence of what we call our red flag symptoms, such as lightheadedness, dizziness, blacking out, this is a very, very common scenario. And there's a really nice clue in there, which is the caffeine intake here. And caffeine is quite a trigger for these skip beats. And actually what they are, they're not always skip beats. They're usually extra heartbeats, what we call ectopic heartbeats. And they're often perceived as a powerful thud in the heart. So this is quite a common scenario. It's often benign, but it does need assessment.
Yeah, good. So generally, I think we all get palpitations every now and then. The vast majority are benign. They're triggered by stress, caffeine. Alcohol is another critical one. But there are a minority due to more concerning heart rhythm disorders. Someone mentioned atrial fibrillation and ablation. Why don't you tell us about atrial fibrillation? Who should have an ablation? What is atrial fibrillation? Why is it a concern, and who should have an ablation?
There's quite a few questions about atrial fibrillation. So atrial fibrillation is a heart rhythm disturbance. It's the most common sustained heart rhythm disturbance. And it's an irregularity of the heartbeat, where the heartbeat, rather than beating in a regular fashion, beats in quite an erratic fashion. And it can present in lots and lots of different ways. One of the most common ways in which it presents is palpitations, this awareness of your heart beating very irregularly. But it can also present in other ways, such as breathlessness when you exert yourself. It can also present with fatigue, for example, sometimes lightheadedness or dizziness. These are the most common types. Very rarely, the atrial fibrillation can be very fast. It can be quite aggressive, and patients may end up in hospital because the heart rate is too fast and they need more aggressive medication to control that. But in a lot of patients, they may have atrial fibrillation and they're not aware of it. And the key issue with atrial fibrillation is to get an early diagnosis because it can have implications depending on your overall risk in terms of your overall outcome, such as small risk of a stroke in selected patients, not in everybody, but it is associated with the risk of stroke. So you need a very careful assessment under these circumstances. Ablation is one treatment. It's only one small part of the treatment. The most important aspect of the treatment of atrial fibrillation is to get the right diagnosis, modify your lifestyle, alcohol, caffeine, bring your blood pressure under control, exercise, weight control, all the things that we've talked about in terms of the issues around narrowing of the arteries is also important in terms of the electrics of the heart as well.
Perfect. Brilliant. Thank you for that. So Far, thank you very much for taking this selfie this morning to kind of demonstrate how we capture arrhythmias. So we don't use the traditional Holter monitors. We have what we call patch devices that you can just stick on the chest. Now, the beauty about these devices are they can record your heart rhythm for 14 days. And why is that important? It's because when you have palpitations, we know that palpitations are a symptom. What we want to understand is whether there's an underlying heart rhythm disturbance. And for that, we need to get correlation of your heart rhythm. So we need to capture the electrical activity of your heart when you are having palpitations. And with these patch-based devices, which we have used for the last 7 or 8 years, you can wear them to bed, you can shower in them, you can exercise in them. You can't swim or immerse them in a bath, but patients love it because they're comfortable. And we love it because the fact that actually quite often we will either be able to underpin what arrhythmia, if any, underpins the symptoms and either reassure or initiate the appropriate treatment. So now let's kind of move on to a third case. This is a 38-year-old chap. He's gone for life insurance medical. Nurse checks the blood pressure, initially 174 over 100. After about half an hour rechecking it, the minimum they get it to drop to is 154 over 94. He's asked to go and see his GP, who then refers them on to us here. Shai, what would you do with this chap? His blood pressure is 155 over 94 high. I mean, what would you consider a normal, target blood pressure?
Thanks, Ravi. So yeah, 154 over 94 is high. The new guidance would suggest we should be aiming for a blood pressure of less than 130 over 80. This would suggest this gentleman does have high blood pressure. And the reason to be worried about this is that the high blood pressure is the biggest cause of morbidity and mortality globally. And the problem with blood pressure is generally you don't know about it. It causes no symptoms until you develop the visual disturbance, the stroke, the heart attack, the kidney failure. And by which time it's too late. So I would be concerned for this young gentleman.
So would you start him on tablets?
So I think we need to do a few more investigations. I think a detailed history here before we jump to any pharmacotherapy and any medication. It's important to understand if there's anything driving it. So a detailed history into his diet, his lifestyle, exercise, family history. But I think he is heading towards medication. We would probably do a few tests beforehand just to see.
So can I ask, we talked about diet, and diet's clearly something that is been a point of discussion. Would you give them the Mediterranean diet, or is there any other diets that are more suited for high blood pressure?
So there's something called the DASH diet, which is a little bit more suited for high blood pressure, concentrating on low salt. And so that's the key thing. And what I tend to say to my patients with high blood pressure, by being brutal with salt in your diet, it's equivalent to taking a blood pressure tablet.
Yeah, so the DASH diet is basically the Mediterranean diet, but with the Mediterranean diet makes no mention of salt. The DASH diet focuses on low salt, really cutting down alcohol significantly, if not at all, if not out altogether, and also cutting out refined sugars. So a lot of commonality, but sodium. What about potassium salt? What are your thoughts on potassium salt?
I don't think it's a bad idea. Potassium itself can lower the blood pressure as well, and it replaces the sodium. So I think that's a good idea.
Great. So would you, any particular test to assess his blood pressure further that you do?
So I'd probably do an ambulatory blood pressure monitor. So I suspect some of my some of the attendees here have had the pleasure of having an ambulatory blood pressure monitor. It's not the most comfortable bit of equipment, and it's not something that I would use long term. But for the first diagnosis, I think it's very important for us to get a clear idea of where we stand in terms of how severe the blood pressure is. And so this is a nice example of an ambulatory blood pressure monitor. And you can see a few things here. What we look for in an ambulatory blood pressure monitor is the average during the daytime, but also the fact that your blood pressure should drop at night, which this patient's blood pressure does very nicely. And then you can see when he wakes up in the morning as well. So he has a good night's sleep. And actually, when we do the blood pressure here, his blood pressures aren't too bad at all. We suspect now, given that his blood pressure is well within normal range, or just within normal range, that actually he's probably got something called white coat hypertension. And it's probably the doctor's fault that his blood pressure was high.
Yeah. So would you, I mean, obviously you wouldn't start tablets. Would you suggest any kind of follow-up? How should they keep an eye on their blood pressure? I think checking it in an insurance medical or in a doctor's surgery is probably not the best way. What's the best way of doing this then for someone like them?
So I think if you're borderline, and the lower number is borderline, 79, 80 is where you need to be. What I don't want to do is medicalize someone who's otherwise fit and well. So nowadays it's very easy to get a home blood pressure monitor. And all I tend to do is suggest that they do some home recordings in about 3 months to see how things are, and they can always email over to the clinic for us to have a quick look. And if that's okay, in 6 months' time. And the home recordings are 5 consecutive days, 3 recordings in the morning, 3 recordings in the evening, and just jot down the number and send it across to us and let us do the thinking. That's how I would manage a patient who's borderline like this.
Yeah. So just some kind of concluding thoughts. High blood pressure is the leading modifiable risk factor for heart and circulatory disease. That basically means it's the risk factor that you can actually do something about. So for every 20 millimeters of mercury that your blood pressure is above the target, you double your risk of a heart attack or stroke. We reckon 30% of adults in the UK have high blood pressure. It's about 16 million, and about half of them are not receiving effective treatment. 10.5 million people in the UK have been diagnosed with high blood pressure by their GP, which is about... the problem is about 5 million have remain undiagnosed. We're only really capturing a proportion of these potential people at risk. Around 50% of heart attacks and strokes are associated with high blood pressure in the UK, which is why it's absolutely critically important that we identify it. So if you haven't had your blood pressure checked, please do. And it's thankfully easy to treat. And the good news is there's lots you can do with diet and exercise, social habits such as drinking too much alcohol, maybe even too much coffee. I certainly think once you drink above more than 3 coffees a day, your blood pressure will start feeling the effect of that. We've kind of really support this initiative of knowing your numbers. So make sure that when you see your GP that your blood pressure is at target, and the new target is 130/80. We've spoken about cholesterol. Let's talk about weight now, because that's come up. We talk about BMI, which is the ratio of your weight over the square of your height in meters. And BMI is something that is used to kind of measure whether you're overweight or potentially obese, with a BMI of over 30 being considered obese and a BMI of 25 to 30 being considered overweight. There are now a range of medications available where you can actually treat people with obesity with injectable therapies. These drugs were actually initially used for treatment of diabetes, but what they found was that not only did they bring down your blood sugar, they made you lose up to 10 to 20% of your body weight. And why is body weight loss so important in terms of your cardiovascular risk? What does it do to your blood pressure? What does it do to your cholesterol and sugar levels? Yeah. So, Shai, I mean, do you notice any difference in your patients who've lost weight?
Yeah, so positive effects on your blood pressure, reduces your insulin resistance, so less likely to develop diabetes. Yeah. Your LDL cholesterol goes down. So all of these things just by maintaining a healthy weight. And in order to maintain the healthy weight, obviously you're exercising. So that's also good for your cardiovascular health. So I think increasingly waist circumference and BMI will be a priority. And the injectables, which I'm sure you're about to lead into, will be a mainstay for cardiovascular health. I think they're going to change the landscape massively.
Absolutely. I mean, there are dozens of trials looking at the effects of these drugs that we looked at it. We know they work in diabetes. We know they work in weight loss. But in terms of alcohol addiction, in terms of heart failure, in terms of heart attacks, where these are all, and hypertension as well, these are all coming. So let me just give you a 2-minute potted kind of history and all you need to know about these drugs. These are injectable therapies called GLP-1 analogs, which you typically take once a week. There is one oral formulation available, but it's not as effective for weight loss. And typically you inject these medications, they mimic hormones that make you feel full. So they basically suppress your hunger. And the effects on weight loss are absolutely superlative, losing 10 to 20% of your body weight. And these are great for people who are carrying so much weight. It's just absolutely impossible for them to start exercising. And once you get going, that encouragement that you get is fantastic. There are obviously side effects. The side effects typically are gastrointestinal related. Initially, you get nausea, kind of abdominal bloating, but that's why we start on low doses, gradually increasing them dependent on weight loss and side effects. Very rarely, it can cause a condition called acute pancreatitis, which is an inflammation of the pancreas and potentially life-threatening. But the risks of that are very low. And obviously, we counsel any patients we give this medication to. In rodent studies and animal studies, not in human studies, in very much the preliminary animal studies, it appeared to cause a rare form of thyroid cancer. So we make sure there's no family history of thyroid cancer, or obviously the patient themselves doesn't have thyroid cancer. And if you are diabetic, it can make your diabetic eye disease worse. But otherwise, these are actually very good drugs. For me, the real concerns are that people tend to reach for them before embracing the absolutely critical strategies of nutrition and exercise. Because the problem is if you reach for it, you lose a load of weight and then you stop it, the weight will just come back and there's also a chance you may overshoot. So you've got to use this in concert with a careful dietary program, nutrition program, a calorie deficit, and your exercise program must have higher levels of resistance training, because the problem is this will not just burn fat, it will burn fat and muscle. So you want to burn fat and try and preserve muscle. So I think weight training, strength training, resistance training, whatever you want to call it, is absolutely critical. The government, as you would have seen on the news, are now fully behind it. There was a problem with shortages of the availability of the drug. That is now no longer the case. These are very easily and widely available drugs. You can actually go on websites and order them. I'm not entirely sure that's the right way, because the kind of controls and the counseling is not the best. I think speak to your GP. Certainly in One Heart Clinic, it was one of the drugs I prescribe most widely, because I have lots of people who are overweight, who've got high blood pressure, who've got coronary disease. And I think this genuinely makes a difference. And I've seen great success in people desperately trying to exercise who now have finally kind of got through that initial inertia, and yeah, they described it as life-changing. So this is just the beginning, I suspect, as Shai suggested, and there's a lot more to come. These are drugs I think will change the landscape. I don't think that's an overstatement. That's a well said, Shai. And we will be using them for a greater range of patients. We won't dwell on this. We've kind of already covered all of this: diet, exercise. Don't forget mental health. I think we're all guilty potentially of trying to internalize things. Reach out to friends, families, healthcare professional. And certainly work is great, but remember to have fun as well, have socialize. And optimizing all of these things, your diet, exercise, sleep, they're all small gains, and we shouldn't underestimate them, because all together can be as powerful as many medical therapies, including tablets and procedures. Let's talk about social habits. Smoking is a terrible idea. I mean, don't smoke. What about vaping? Do you think vaping, what do you say to people about vaping?
My goodness me, the evidence for vaping is absolutely terrifying.
Yeah.
So if we speak to our respiratory colleagues, there's clear evidence and signals, even in this short period of time, of severe disease to lung tissue. So scarring, fibrosis, which is far more of a stronger signal than there was with smoking. So I don't think vaping is a safe alternative.
No, it's not. It's fine. It's better than cigarettes, but you should use it as a bridge to give up smoking. And I sincerely hope the kind of laws are tightened so that we don't see people queuing up and newsagents buying colorful, fragrant vapes. There's no link to cancer. The key word is yet. It's clearly coming. There are already studies showing that it changes your cheek cells, and those are the first kind of studies before cigarettes were definitively shown to cause cancer. Alcohol, look. Alcohol is something that some of us enjoy, and some of us probably enjoy a bit too much. I know my Friday evening glass of red wine is the way that I kind of kick the weekend off. It's a drug, and it makes you feel good. But frankly, there's no health benefit. The tale of, a couple of glasses is good for you, that's not true. A couple of glasses is not going to do you any harm, and up to 14 units aren't going to do you any harm. But it's actually linked to high blood pressure, stroke, and heart disease. And the right amount of alcohol to drink is actually none. I don't drink none. I actually drink probably around the 14 units. And the only way I can do that is by not drinking Monday to Thursday. and then really being careful on the weekends. So alcohol is really for enjoyment. There's no health benefit. Stress, I mean, this is something that we just can't quantify, but we all have experience in people who are otherwise well in every regard. But stress creates a surge of this hormone called cortisol, which itself can be atherogenic and cause buildup of fat. So stress is something that easier said than done. But if you can manage it, please do. If you can't, use every outlet and every strategy that's available for you. Caffeine, a little bit is good for you, 1 to 2 cups a day, more than that, and it's not actually doing you any good. But actually, unlike alcohol, it is thought that there's lots of antioxidants, and although caffeine initially raises your blood pressure, if you take 1 or 2 cups a day, it actually probably reduces it overall. So that initial spike will gradually settle. Finally, I'd just like to talk about women and heart disease. And we take any women, young, middle-aged, or elderly, coming into our clinic with any form of symptoms very seriously. And the reason we do is, unfortunately, I'm ashamed to say that as doctors, we have in the past not taken the complaints of women who present to our hospitals, GP surgeries as seriously as we should do. And as a result, a woman is 50% more likely than a man to receive the wrong initial diagnosis for a heart attack, and are less likely to receive life-saving treatments. So that's something that we are very aware of. We also know that women tend to put their families first, tend to minimize their symptoms. If you are a woman and you have symptoms, don't keep them to yourself. Come and share them with your doctor, and it will be taken seriously. This is a lesson that we've all learned. And I think we've done very well here. We're going to come to 7:30. One thing before I say goodbye. We are shortly to be launching a really exciting new digital platform that will allow you and us to keep in touch, to track all these important parameters. Every time we have blood tests, blood pressure readings, you can put it in a downloadable app. We'll have sight of it. We'll have a kind of recipes, exercise programs. There's an element of AI that kind of helps us figure out where you need support. So watch this space. So I think at that point, I'm going to stop. I'd like to thank all of you who stayed to the end. I think the questions have been great. It's always telling when there are lots of questions. Shah and Fahad, thank you very much for your insightful input. And maybe we just end by asking if there's any final questions that's worth addressing, but otherwise we'll bring the evening to an end.
There were a couple of areas and topics that we didn't get time to address. So cardiac health in the menopause, for example,
Yeah.
and the importance of sleep. So I've said that we will address this in a future webinar.
Agreed.
And menopause and women's health is a very popular question. I think we should do it.
And I think for that we should probably get a suitably qualified gynecologist who has an interest in it to partner up with it.
Yeah.
So that will be a priority for us on the future webinar.
Brilliant. Okay, thank you very much. If you have any feedback, please do email that through. Stephanie and I will talk about potentially sending out a questionnaire. This was the first time we've done this. Hopefully it won't be the last. And I wish you all an excellent rest of the evening. And thank you so much for your attention. Goodbye for now.